Capital Blue Cross stops. They've probably already spent $21 to $25, $30,000 on all her preventative tests, her little procedures she got done. But now she's a healthy chain smoker again. That's abusing the system.
Well, what I would say is that we can always look for example. I would say that's definitely the exception, not the rule.
Not the exception. I've been doing this since Obamacare came out.
Okay.
I'm sorry.
Well, that's your opinion, and you.
It's not my opinion. I can show you the numbers.
Okay. Well, you can. Okay.
We have questions at the end.
Continue
Yeah.
the presentation.
Absolutely. Absolutely.
Thank you.
Yes. Okay. So, you know, like I said, there's always going to be disagreement about the best way forward. I think in terms of PHAN's platform for 2017, affordability, increasing transparency and competition so that there's more of a choice of plans in each region. I think even greater protection. Some states have gone even farther than the guidelines suggested by the Affordable Care Act for involvement in justifying rate hikes that are requested by insurance companies, and there are public hearings and people can come and ask questions of the insurance companies, and then there's an investigation of whether or not those rate hikes are really justified. But I think the part of what we're feeling is growing pains from breaking out of the race to the bottom model. And the race to the bottom mentality infects and affects a lot of different areas of our lives in terms of big box stores, you know, closing down Main Street shops that provided good jobs. But especially in terms of these junk insurance plans that people had before the Affordable Care Act, they had high deductibles, they had lots of holes, so people thought they were covered and then they tried to use it for something and found out it didn't cover what they needed. And so the Affordable Care Act said, you know, people should have coverage that means something. When you pay for health insurance, it should pay for your care. It should include maternity care for survival of the species. You know, we don't all, you know, it covers, you know, prostate cancer screenings for men. We don't all have the same ailments. We don't, you know, you can have bad health behaviors that aren't smoking. You know, we're all different. We all have to live together in society and make it work. And, you know, these are the growing pains of deciding that we're going to be a society that looks after each other, that protects Medicare, and that looks to protect Medicare by helping people that aren't yet 65 have health insurance and take care of themselves. Hopefully that woman that you talked about stops smoking. Maybe she will. You know, for a lot of people it takes that diagnosis to, you know, to finally quit. But the answer is not to deny more and more people health care. That's just not, it doesn't make moral sense and it doesn't make economic sense. And I think you know, the country has kind of decided on that across a couple of election cycles and certainly across 2017. So I wanted to put this up on the screen. When we do community events with people to talk about health system transformation issues and policy, this is really where the conversation needs to shift, because so much of the money in our healthcare system is spent on chronic illnesses like diabetes and COPD, and also on long-term services, but a lot of that money is going toward medical stuff. And if it was diverted a little bit earlier toward social supports, toward helping people eat healthy food, which is more expensive than junk food, helping people have a safe place to exercise and talking to them about the importance of, you know, healthy lifestyle habits. But it can't just all be talk. People have to actually have the opportunity to do those things. And so what puts us in the hospital? Just shout it out. What kind of things put us in the hospital? Accidents. Mm-hmm. Illness, yeah. Heart attacks. Yeah.
Bad habits.
Bad habits, definitely. What helps us stay out of it? Good habits. Yeah. But, you know, a support system. Somebody to help make sure you take your medicine on time. Somebody to help if you have a friend or loved one that has multiple chronic illnesses like my mom. Ask questions if doctors prescribe medications for one thing that aggravate a condition for another thing. What do we need to live well? What's it?
Healthy habits.
Healthy habits.
Good health.
Yeah.
Wellness checks.
Yeah, wellness checks, preventive care. Absolutely. And social isolation is a huge problem for older adults. Loneliness can kill, right? And so we need communities that are better connected. We need to get people in the door earlier into our healthcare system, but also empower people to take control of their lives and to have the tools to actually build healthy habits. You know, we can't just sort of, and there's a real, I don't know where it comes from necessarily, but there seems to be a real impulse to kind of punish other people, you know. I think, you know, hearing some of my older relatives talk, there was much more of a sense of humility in terms of the situation of other people, and now we often look for opportunities to blame someone for their situation, and I'm not sure how helpful that is. I think it can be emotionally gratifying. I certainly, you know, slip up and do it sometimes. We all can, but it doesn't necessarily lead to good policy. So I want to see here, I covered this a little bit in terms of so just some numbers. Right now we have 2.6 million people that are covered by Medicare in Pennsylvania, 865,000 older adults and people with disabilities that are covered, and about 400,000 people that are covered by both Medicare and Medicaid. And so to be covered by both Medicare and Medicaid, you have to have a low income and low resources. So less than about $1,000 a month for a single person, less than about $2,000 in resources. So these are typically older adults who are more at risk for things like social isolation, poverty, not having enough healthy food. Just to share a story, I met a woman named Joanne at a senior center in Pittsburgh. She gets by on about $800 a month, and you know, her apartment is rent controlled, but most of her money goes to utilities, and her grandson, who's in 9th grade, who has autism, lives with her, and the relationship with the mother is strained. So she's doing the best she can while managing her own diabetes and COPD and needing a knee replacement and recovering from another one to take care of him and her, to eat healthy, but she's barely hanging on. And so if our healthcare system can figure out how to better support people like Joanne, they won't need as much high-end medical care down the line, just by increasing social support and dealing with what in technical wonk speak is called the social determinants of health. You know, connectedness, poverty, transportation, isolation, housing. Housing is a huge determinant of health, and we have a Housing is Health Coalition right now that's working with the state Medicaid department to figure out if Medicaid can reimburse for any supportive housing services to help people find a safe place to live. Because we know that when people are homeless, where do they go? Often. Emergency rooms, to the most expensive place in our healthcare system. So let me pause and see if there are any other key concepts I wanted to cover, and I'll pause and take one or two questions. Okay.
The term race to the bottom, I know generally I get it, but in this context of medical, could you give me some more specifics about that?
Absolutely, that's a great question. So for a long time, insurance companies held all the power and could use medical underwriting to deny people that had pre-existing conditions health care or to charge women more. And so you had this dichotomy of people that, you know, could buy these junk insurance plans because they wanted to. They didn't really need it, but they just wanted it in case of catastrophic cases. And then you had people that either couldn't get insurance at all or would maybe pay for it for a year before it would kick in because they had that lockout period. So when you allow, if there's no standard in terms of what a health insurance policy has to cover and how it has to treat you in terms of not discriminating if you've been sick or because of your gender, if you don't have any standards, plans are going to want to charge you a lot of money and try to not pay for things when you need it. So that's what I mean by race to the bottom. And the Affordable Care Act set a standard to say that, yes, there should be essential health benefits, and that should include maternity care and preventive care and mental health parity, also very important. And so what the current administration is doing by, you know, allowing through executive order some of these junk plans back into the market is a way to siphon out the healthy people. You know, insurance works best if the risk is broadly shared, if you have both healthy and sick people in the pool, and that's why the personal responsibility penalty is in there to get healthy people in, to say, okay, you might think you're invincible, none of us are, so either buy a policy, which we'll make affordable through the tax credits. People can buy catastrophic policies. If they're under 30 years old, they can buy a bare bones policy. In a lot of places, especially in the first couple years, and I think even still, but I didn't do enrollment directly in the last year, people could get bronze plans for like less than $10 a month. And these are Affordable Care Act compliant plans. But you can get a bronze, a silver, a gold, or a platinum based on what you expect your medical needs to be. So if there's no standard, it's going to erode. And the only things that will be available are plans that cost a lot or are impossible to get. And we saw the consequences of that for people's, in terms of medical bankruptcy, in terms of health consequences, and then also in terms of Medicare, leaving Medicare to solve the problem of, all of the uninsured population showing up with, untold number of undiagnosed issues.
Yeah. So, our founding patriot mothers and fathers back in Philadelphia next door developed the first insurance companies for fire, life, flood, and so forth with the express purpose, unless I read the history wrong, the whole point of insurance was to share and spread risk. Whatever happened to that concept?
Well, if you didn't join that society, though, your house burned down.
Yeah.
And that's basically, that's what this program is doing.
Yeah.
The younger people are electing to take a chance their houses are gonna burn down.
Yeah.
It wasn't mandatory. You could join one of those societies, have a black book here. But I'm not, please don't misunderstand. Remember what I said. I feel we should have started this out defining what is covered to match exactly what is covered with Medicare. And I would go on the pregnancy thing, but there's a lot of stuff covered under Medicare preventative. Why did we have to recreate the formula? The other thing,
Medicare actually didn't cover preventive care until the Affordable Care Act. That was the,
okay, all right. So then we expanded that. That's good. I don't have a problem with that.
yeah,
Sure.
yeah. So, I think that there's also a lot of work that can happen at the state level. The Affordable Care Act, again, set a standard to stop the bleeding, to put out some of the fires in the healthcare system. But there's a lot of reforms that can continue to happen at the state level. Some plans created basic health plans that are sort of similar, if anyone remembers Adult Basic. That was a great program for people that were sort of working income but made a little too much to qualify for Medicaid. So states have a lot of authority to design healthcare programs that could work in their state. Pennsylvania decided not to set up its own marketplace. I just heard, and I don't, often we get mixed messages from the administration about what's going to happen or not, but I heard that they may try to defund all of the marketplaces. So we really have to hold on to what we have as we're working to make it better. I think that's another big takeaway. Real stories in real time, and hold on to what we got. And I think you don't realize what you have until it's gone or almost gone, and a lot of the, initial sort of dissatisfaction around why isn't the Affordable Care Act perfect and solve every problem, that was never possible, especially not in a divided country and in a divided Congress where people had a lot of different ideas about what should happen. But it really shored up the foundation for us to build on. We can build on it at the federal level or at the state level, but I want to be mindful of time. Some of the most important things that you can do are to regularly develop a relationship, if you don't already have one, with your state representative and your state senator. Go to their events, talk to them, develop a relationship with the constituent service staff. Encourage your friends who need help getting information about healthcare to talk to their offices. If it's a state representative that's hostile to Medicare or Medicaid or the Affordable Care Act, share positive stories about who it's helping, the people in their community. Because those same representatives, and I'll share the story of Mike Kelly, one of my earliest one of my earliest formative experiences growing up in Newcastle in Lawrence County was going to the food bank with my mom to volunteer. And sure enough, there was Congressman Mike Kelly, who is very much against the Affordable Care Act and Medicaid, there at the food bank, serving people who go there, many of whom are covered by Medicaid. So, they want to go out, they want to generate positive goodwill in their community, but they want to compartmentalize everything. So we need to not let them do that. And everywhere they are, in public and through letters to the editor, through calls, social media is fine, but you can waste a lot of time. I would say coordinate amongst yourselves on social media, but getting into it with people on the congressional Facebook page has not been a good use of time when I've done it. But these other more public arguments and sharing those personal stories, when you have to sit across the table and look somebody in the eye and hear about how access to healthcare saved their life or improved their quality of life. That, you know, if it doesn't turn someone into a supporter, they might at least be less hot of an opponent. And that's a little bit of progress. So I'll leave you with those hopeful words of wisdom here. But definitely stay in touch with us as an organization with PHAN. I can share, along with these few slides, our formal policy agenda. There's work that can happen, well, certainly reactive defense work that should happen around stopping work requirements in Medicaid. Medicaid is now almost as popular as Medicare nationally. 7 in 10 Americans, and this is according to the Kaiser Family Foundation, strongly or you know, actively or moderately support Medicaid. But support's also high for work requirements, and I think this gets back to that issue of, you know, I have to work hard, I want to punish somebody else based on whatever their situation is, and we don't know what people's situations are. I can share stories of people that I've worked with. A woman named Susan, who I just helped sign up for Medicaid last month, she lives with her husband, who's older. He's in his late 70s and has a lot of serious health conditions. He's a veteran and needs basically someone to be with him at all times to make sure he doesn't fall, to take his medicine. She also has a 28-year-old son who has developmental disabilities. And until I signed her up, she was uninsured. So now she has Medicaid, but can someone in her situation, should she be punished because she can't work outside the home? She's not technically disabled. She needs a hearing aid. She has trouble hearing. But these are the kind of situations that we know a lot of our neighbors are in. And this is exactly the kind of person who's going to get hurt by work requirements. There are certain carve-outs for people with disabilities, but it's a paperwork issue. So the population of people who are covered by Medicaid, who are not already working in the service sector or self-employed, a lot of the people that I've signed up for Medicaid over the years are freelancers. They're landscapers, they're bartenders, they work at the hair salon, they're waitresses and waiters. So a lot of people are already working. Those who aren't primarily are not working either because they're students, they're in school furthering their education, or they have family caregiving responsibilities. So the work requirements, the best way to make the case against work requirements is to talk about them as an unnecessary administrative burden. That it's beefing up state bureaucracy, putting all this money into, the paperwork police, and they're searching, forcing people to jump through all these hoops, and it's a way to cut the program. So the public is also very much against Medicaid cuts, so emphasizing that work requirements are a way to cut the program, and then that opens the door to talk about, well, how would they cut it? It would kick people off if they miss a deadline. A lot of people that are lower wage workers don't always get nice pay stubs emailed to them, right? It's hard to get that documentation together to be constantly submitting it to the county assistant's office to keep your health care. People should have health care. Yes, if we want to work on job training programs, if we want to put more money into vocational education and community colleges, that's great. We should do that. We should leave healthcare out of it. People need to be healthy enough to work, not the other way around, right? So that's a big priority. We talked about prescription drug costs and ensuring that that baseline, that standard that was set by the Affordable Care Act in terms of people having coverage that actually means something, that covers them when they're sick and when they need it, that cannot be eroded. We want to build on that, not let that be picked apart by all these different schemes like across state lines and reintroducing junk insurance plans.
Speak about drug costs, and maybe this doesn't relate to anything, but I can watch TV for a while and see ad after ad after ad for pharmaceuticals and for insurance. What relationship does that have to the costs?
Well, under the Affordable Care Act, insurance companies, not drug companies, but insurance companies can't spend any more than 15% of their profits on administration, including advertising. So that's at least some check, but some states have made it 90%. That's an issue that we could continue to work on. There could be something like however many dollars in a certain media market you're putting in, 15% of that has to go to public health or something like that. There's different ways to offset. If we can't sort of ban insurance companies from direct advertising, I think that cat's out of the bag. figure out how to divert some of that back toward the public good. That's actually what happened with the, going back to Merchants of Doubt, with the Tobacco Settlement Fund. State Attorneys General, there was a big tobacco settlement in a lot of states that goes to fund long-term care programs. It funded adult basic before that was cut under Governor Corbett. So finding a way to offset the harm.
What are we doing though for the pharmaceuticals? That seems to be an area that you can't seem to control. I mean, I know what I pay for my medication is terrible.
It is. It's terrible, especially for brand name drugs or drugs that are patented. Just outrageous. There is a state bill, and I have to apologize that I don't. Let me see if I can find it here. This is where you're missing out on Patrick, the policy person, because he can recite these bill numbers in his sleep. But there is a state bill that would work on improving transparency and cost of prescription drugs, and I'll write up a little blurb about that and make sure people get it after the meeting. And I apologize, I just can't seem to find that right now.
Okay.
I think, and also, I believe Senator Warren, Elizabeth Warren of Massachusetts, had a prescription drug bill, or has a prescription drug bill at the federal level, letting Medicare negotiate drug prices and use the buying power of all its beneficiaries would be a really good step, and the AARP has worked on that nationally, and a lot of elder rights groups have as well. Sorry, I don't have a better answer on that.
Yeah, I guess a couple of things. One of which is that I sort of take sort of the long view of this in terms of we've got a work in progress that we need to continue to work on, because as far as concerned, I can remember starting out what nursing homes, many nursing homes were 40 years ago, and where they are now is very different. But we have, I think, at least one continuing issue, and it came up over 20 years ago when they talked about managed care, and it relates to the proposed merger that we've got in terms of the local hospitals, in terms of how much time doctors can spend with you. But then probably the one question I have, which is sort of really more to update myself as far as concerned, is that at one point, the best way to be able to qualify for nursing homes, and in order to really qualify for financial support, was by being admitted through the hospitals. Is that still the case? You know?
That's skilled care. That's
That-
not nursing home.
So if you're admitted directly from the hospital and you have Medicare, Medicare will pay for, I think it's 120 days in a skilled nursing facility, but it's for the purpose of rehabilitation. After that, and it can help because, the hospital social worker can get involved and help, think ahead and help someone get a Medicaid application in or counsel them about their options. I would definitely encourage people to talk to elder law attorneys about things like trusts, if you want to set money aside for your family. There's a look-back period of 5 years to see if you've transferred assets, and you can be penalized for that by Medicaid because they don't want you getting rid of all your assets so that you can qualify for Medicaid-funded long-term services. So there's a lot of issues that we need to work on. Like I said, the asset test, but just personally, and that's an issue why long-term care is so problematic, because we don't really think about it until we're so close to needing it. And so there is long-term care insurance that people can get. It helps if you get it younger, earlier on in life, but I would definitely like to see a movement for long-term care reform to make it easier for people to get these services sooner, so that, right now, and this mirrors what happened in our private insurance market, we would wait until people were so sick and desperate to let them qualify for Medicaid under the old rules that it doesn't make any sense. And we shouldn't make people wait until they're isolated and have fallen and are in the hospital to finally qualify for long-term services. So thinking ahead and proposing proactive solutions to intervene earlier. And that's what Governor Wolf says is one of the goals of Community Health Choices, which is not coming to your region until 2020. So you'll see me again then for sure. But it's starting in Western Pennsylvania, and the goal is to improve care coordination and support for people that are called dual eligibles. They have both Medicare and Medicaid, and it includes people that have Medicare and Medicaid because they're low income and they might have chronic illnesses, but they don't yet need long-term care that's that intensive. It also includes people that are getting those waiver services in the home, and the hope is that managed care organizations can better support people, check in with them on a regular basis, more quickly identify when their needs are changing. If someone needs like grab bars in the shower or a chairlift or an exterminator to come or something like that, they can get those things before they're fully eligible for everything else, because it's cheaper than letting someone have to decline and go into the hospital for 2 weeks and maybe get a staph infection and then go to the nursing home. So managed care, and this is where the sort of next generation of healthcare reform issues, there's no clear heroes and villains. In the pre-Affordable Care Act days, insurance companies that were denying people care were a pretty clear villain, and they had a financial interest in doing that. So they weren't doing it out of malice or malicious intent, but in dealing with a population that has Medicare and Medicaid and figuring out how to keep people well, everybody is on the same team trying to figure this out. So managed care companies aren't necessarily a bad force. They have to be held accountable, and there have to be measures in place that they are accountable to the state and to participants, but they have a financial incentive in keeping people healthy. So it's a long game process, like you said,
I have another question concerning cost. I learned more recently that UPMC, University of Pittsburgh Medical Center, is now the largest employer in the state of Pennsylvania. And they continue to increase their monopoly power to set prices by buying up other healthcare facilities around the state. So my question is this a concern? And if so, what are we doing about it?
That's a really good and a really hard question. UPMC did in Lawrence County, where I'm from, they bought up a local hospital, Jameson. The merger with Pinnacle. We could make an argument to the state attorney general that the consolidation is going to hurt the health of the community and hurt people's choice, but the trend nationally is in insurers and health systems integrating to share the risk of caring for someone. And so the goal is to save money, to keep people healthier and to keep people out of the expensive setting. But when that leaves people, especially in rural areas, with the choice of only one health system, that's not good either. So there is no quick political solution for this other than getting involved, going to any public hearings, contacting the state attorney general's office, the state insurance commissioner, the people who are approving these merger decisions. But also the other thing to know, and I'm glad you brought this up because it reminded me, nonprofit health plans, managed care companies, also community hospitals or a nonprofit in name like UPMC and Allegheny Health Network, they have to have community advisory boards made up of people from that community. So that's those are some of the places we train people to have an impact, because we think of calling our elected officials, we don't think of going to the hospital and asking, where can I, as a consumer and someone who lives in this community, weigh in on the relationship between the hospital and the community? And so these advisory boards are federal requirements to let the community have some oversight, some accountability to demand those things from the hospital. There's community benefit agreements. A couple of years ago, this was also part of the Affordable Care Act. They required nonprofit hospitals to conduct a community health needs assessment and then develop a plan to improve the health of the entire community and look at things like health disparities and rates of chronic illness. So I'd have to refresh my memory and see what the structure is locally, but nonprofit hospitals have to do that. They have to do a community health needs assessment and have some kind of a consumer advisory board. So that's a place that you could get involved, have more influence.
Why does PHAN not give more consideration of improved Medicare for all at the state level or the federal level?
I don't think it's an idea that we disagree with. I think it's an issue of political will and political feasibility. So what we've always focused on are things that we can win right now or defend against right now. But I don't see any reason for us not supporting it. I just know that in our Pennsylvania political environment, it's been very tough to make progress. And we have started to make some progress on issues like balance billing, and issues around like transparency. You can get some bipartisan support for, but the issue's been so polarized that it hasn't been on top of our priority list, but we're not opposed to it at all.
Because all these things you've been talking about, the whole meeting, the excessive cost of health care and the unaffordability of health care comes down to the greed in the middle of health care. And it is widespread. There is no power in our country other than the government that can get control of that. As long as profit drives our healthcare system, as opposed to human care being a human right, we will have the disaster we have, and it will only get worse. So I would strongly encourage you at least to keep your ear to the ground on the groundswell that I think is starting to occur as more and more people get burned by our present system. I'm a family physician. I was a conservative my entire life. About 10 years ago, I flipped. But that being said, this is an issue that everything we're talking about, and Bob Wagner and I think, respect each other. But on this issue, we probably come at it from 180 degrees difference. But we could narrow the administrative cost of healthcare without insurance companies, one set of rules based on quality of care, standard of care as it evolves, and give billions, hundreds of billions of dollars a year back to take care of people.
I think that's, I don't disagree with any of what you said, and I don't mean to be pessimistic. What I would say is a conversation we need to have is how privatized Medicare already is in terms of the prescription drug benefit and Medicare Advantage plans, and how to deal with the issues around Medicare not covering everything. Because if people don't have a supplement, there's nothing there to help you if you have an extended hospitalization. You need some kind of a supplement, whether it's a Medigap plan or Medicare Advantage or Medicaid if you qualify. So Medicare itself only covers 80%.
If you noticed, I said improved Medicare.
Improved Medicare for all. Okay, that's very important because that's good.
The federal bill, the House bill 676, covers the rest of the cost.
Great.
With a funding mechanism.
Okay.
Our state bill 1688 for healthcare for all PA funds the additional cost.
Great.
Everybody in, nobody out.
Mm-hmm.
Pennsylvania citizen. Plus long-term care, Pennsylvania citizens. So family needs to file a tax return.
Right now I have another separate meeting.
Wait, and that's fine, Bob.
Yeah.
Because Bob's helped a lot of my patients in the present system.
Yeah.
So I'm not throwing daggers at you, Bob.
I'm not throwing it at you.
I appreciate
Might
that.
throw 'em at West.
Well, and that's, I mean,
I'm
that.
asking you, let me ask Mike this one, and we're local here now.
Quick question, please.
Go ahead, Cindy.
No, I mean, he wants to ask you a question. In the interest of time, quick question.
Quick question is, and I'm not in favor of the health insurance companies, especially many of the ones that say they're not for profit. Okay? But let me ask you this, is the health insurance companies that WellSpan deal with driving their not-for-profit president to make $4.4 million a year, and at the end of the year get another $3 million bonus?
So,
Yeah,
yeah,
I mean,
and see, I am still an independent,
Mm-hmm.
but I am collegial with WellSpan. But I truly believe, particularly after reading Stephen Brill's article in Time Magazine and what I've read since then, that what we pay healthcare systems and their administrative staff is a little out of control.
Correct.
So we agree on that.
Yeah.
I don't think that's the whole problem.
No.
And even just negotiating as a nation for the cost of pharmaceuticals in our nation,
Phenomenal.
when we're paying twice as much as any other nation on earth, a whole journal of JAMA was pretty much focused on this one issue of our costs in America, just in the last month, our costs in America for healthcare in all the realms versus other rich industrialized nations. And then the really mediocre quality we've provided, when you look at numbers like
Right.
infant mortality, longevity of life, maternal mortality, and so on and so forth. But if we just took the pharmaceutical piece and we made the companies negotiate, but money in politics has prevented that thus far. And so really that's the bigger problem, is money in politics.
It's money in politics, and it's also what that money pays for, because campaign contributions are significant, and you can go to like Open Secrets and see how many people, what elected officials get from what sources. But a lot of those, a lot of that campaign money pays for fear and smear TV ads at election time, and we just lived through the PA 18 special election in our area. The airwaves were bombarded with the nastiest, most outrageous, lizard brain targeting ads. And so the campaign finance part is important, but we have to inoculate each other against those kind of appeals. And we also, I think, the biggest hurdle for improved Medicare for all is a perception one. We've had, I think people who have opposed progressive issues have really narrowed the terms of the debate over the last 30 years through their media mechanisms, talk radio, Fox News, etc. And so if we have the numbers that show that improved Medicare for all could provide better care at a lower cost than what people are paying today, but because it does it through a tax, it's off limits. So what I would suggest is that we need to have these conversations at the doors, with our neighbors, talking to everybody, especially people that we're not sure where they are on the issue, and try to bring them around. And I know that Healthcare for All and the people in in Beaver County, they actually did a day of Medicare for All canvassing in, one of the Rust Belt towns in Beaver County, and they had a really good experience talking to people. So you can build support for the idea, but it's going to take a big groundswell, I think, of citizen to citizen conversation. So one thing I'll suggest in closing